It is great to welcome back to the program today Dr. Isaac Bogoch, who's an infectious disease physician and scientist based out of the University of Toronto and Toronto General Hospital. Always great to talk to you.
Oh, nice to see you again.
So, I guess just to start with briefly, we're seeing the US number of coronavirus cases down from their sort of second peak, still around 40,000 cases a day. I know you're in Canada. I don't know how closely you're following the ins and outs of case numbers here, but there's some skepticism about whether these case numbers can be trusted at this point, given a lot of different things that have gone on with the data, with testing pause due to weather events, and so many other things. My question to you is there really a better metric to pay attention to at this point, be it hospitalizations or deaths or something else?
In all fairness, I look at a combination of metrics. I think the number of new cases per day is very, very helpful. But above and beyond that, I look at other metrics as well. I look at the 7-day average. I look at the number of tests that are performed. I look at the percentage of tests that are positive out of the number of tests that are performed. And I really think that when we sort of combine all of those metrics and more, we really paint a more holistic picture that gives us a better understanding. Of course, if testing isn't being done, it's hard to know exactly what the ground truth is. But in all fairness, I think it's by this point in time, we sort of know in most regions how things are going and what direction things are turning, either for better or for worse.
So, one specific question on testing and positivity. Sometimes we will see a situation where it looks like in a particular state, cases have gone down. And then when you look in a little more detail, you see that tests are down 30% and new cases are only down 10%, which implies a higher positivity rate. And it suggests that it's because you're doing less testing that cases have gone down. The counterpoint is, well, if the testing goes down, you're probably only testing sicker people. So it makes sense that the positivity rate would go up. It doesn't necessarily mean there are actually more cases out there. Is there any way to know for sure?
Well, yes, there is. And the real answer is getting lots of disparate data sources together in one place. And really, that is why it is so important to look at several metrics rather than just relying on a handful of metrics. And then, of course, watching the metrics through time. An individual day or even a few days really does nothing to us. It's really important to look at longer term trends, 7-day trends and beyond. And I think if we're starting to do that and stop reacting to, terms like uptick and downtick every time we see some variation in the data, we'll be in a much better place. There's going to be the expected normal variations on a day-to-day basis and even maybe on a bit of a longer term basis. But if we look at weekly trends and look at multiple data sources, I think we'll be in the right place. And really, truly, all of those combined together gives us a good impression. I don't think anyone following this is really looking at that, one true metric that's really going to provide all the answers. It's a multitude of metrics.
So let's talk about the next 3 to 4 months. Some of the countries that did successfully flatten their curves are starting to see some more cases. Spain is one example that I've been looking at, and there are many others. In the United States, when we first got down to 20,000 cases a day, things just basically reopened and we went all the way back up to 75. Now we're back down to 40. What is the best assessment now of what was originally thought of in the May projections to be a discrete second wave, which now is just maybe going to be a kind of continuation? What is the timing looking like? How bad could it potentially get?
It's interesting because we talk about the second wave like it has some finite definition. And in all fairness, I don't think it really matters whether or not this is a spike in the first wave, a plateau in the first wave, a distinct second wave. I think a lot of this is irrelevant in the sense that, number one, you still have a very susceptible population, meaning that, in most places, the vast majority of people have not had this infection, so are susceptible to getting this infection. And number two, if you don't have controls in place to keep this infection at bay, you're going to see widespread transmission. So, if we look in the crystal ball, we can predict what's going to happen. If people are in indoor environments in close proximity for prolonged periods of time, we know that this is the perfect setup for transmission. Now, let's think about what's going to happen in the months ahead. At least in the northern parts of the United States, it's going to get cool. We've got kids going back to school. We've got many people going back to work in person. We've got cooler temperatures that are driving us inside. We've got economies that are opening. And all of those just put people together in indoor environments for prolonged periods of time. That is where this virus is transmitted. If we take steps to mitigate that, spread people apart, put a mask on when you go inside, limit the number of people in indoor settings, we can probably do a decent job in mitigating the spread. But I still think we'll probably see a rise in cases, at least in the northern part of the United States and certainly in Canada as we enter the fall and winter months.
So in terms of masks, obviously there's been a lot about masks over the last many months. In particular, there is disagreement, I guess we can say, about the degree to which masks prevent transmission and whether they're really to protect one from spreading versus to protect one from catching, or both. There's a very popular meme that's been floating around, which, it puts numbers to it, where it says, if both people wear a mask, it's like a 1% chance of transmission. If one person wears a mask, it's 5%. If neither one does, it's or whatever, right?
Yeah.
I'm sure those aren't the right numbers, but are there any numbers or specificity to the effect of masks? And then, of course, what type of mask, I'm guessing, is a factor as well.
Right. I think we can talk about this in general principles. And I certainly, just full disclosure, masks is probably my least favorite topic of this epidemic or pandemic.
Interesting.
For whatever reason, this was like the hot button issue. This was politicized to such a degree. People have very, very strong opinions on many different sides of the equation. People are cherry picking data to suit their preconceived ideas. And it's really frustrating when you really want to just take a public health look at this, an epidemiologic look at it, a medical and scientific look at it. It's kind of frustrating. And quite frankly, it's frustrating because people who should know better are still, I think, speaking beyond the data or still cherry picking data. Having said that, there are many rational voices, both in the lay community and in the medical, scientific, and public health community. And I commend those people, because anytime we talk about this, for whatever reason, there seems to be a dog pile effect. Now, let's get to the question. So in general, based on what we know now, we can talk about masks at an individual level, and we can also talk about masks at a population level. I think we can also talk about masks in a healthcare specific area as well. But in general, at an individual level, if you put a mask on and you're infected, you're just going to reduce the amount of virus that you transmit to the environment around you. Seems to make sense. Pretty good idea. Now, does this pan out at a population level? It's interesting. There's modeling studies, which, quite frankly, I work in epidemiology as well. And, a lot of my career is based on working with modeling and whatnot. I've got to say, I should be the big supporter of models. I think models are helpful, but I don't think they really answer definitively the questions that we want to answer. They're helpful, they're useful, but we have to take a lot of the modeling data with a grain of salt. So at an individual level, great. I think it's a no-brainer. We've known this long before COVID-19. If you put on a mask, you just reduce the amount of virus you're going to shed in the environment around you. At a population level, the waters get a bit murkier. Will it really help at a population level if there's masking? Yeah, you know what? At the end of the day, if we sift through the data, it probably helps, but I think it helps to a much smaller extent than what many people might believe or might want to believe. But I'm not saying it doesn't help. I think it does. And then, how do you take this data and translate into policy? I think at the end of the day, we also know where this virus is transmitted. It's almost, well, I shouldn't say exclusively, but it's truly an indoor virus. Like, there's just remarkably few transmissions of this virus that are credible, that have been documented in outdoor settings. Sure, it can happen in an outdoor setting, but it's just not nearly as common as indoor settings. So if we take our data that we have with masks, with the total appreciation that this is imperfect data, with the total appreciation that it's going to be impossible to, at this point, to have a perfect randomized, double-blind, placebo-controlled trial or whatever we want to design. But if we take the existing data that we have, I think it's very reasonable to translate that into policy to say, listen, if you're in an indoor setting, you should put on a mask. I think it's as simple as that. Outdoors, I've seen some of the narratives coming out of the United States with people saying, I went for a 20K jog and I had a mask on my whole time, and this didn't bother me one bit. Mazel tov, we're all very proud of you for wearing a mask, but I don't think you're at risk of transmitting this infection if you're on a 20K jog, and you probably don't need to wear a mask. I'd focus on indoor settings. I think masks are a great idea. Taking the politics out of it, we should be putting on a mask when we go indoors.
Yeah, I mean, I've said this. We'll move on after this. But here in Boston now, if you're just even walking downtown, if you don't have a mask on, people kind of look at you. From the studies I've looked at, it really doesn't seem like that is at all a high risk scenario. But if people want to do it, like you said, Mazel Tov, l'chaim, I'll do it. I'll do it in order to participate, because I don't want to be the person who's not participating. But it doesn't really seem to be based too much in the science.
I think you have a really good point there. And a lot of this bleeds well out of science and medicine and into more sociological or socio-political conversation. I'm sitting here in Toronto. I cannot comment, I cannot empathize on what you're going through in the United States in terms of the degree of politicization that this has had. And if the mask might also represent a lot more than, hey, I'm here to keep you safe in case I'm infected. And I appreciate that there's a lot more going on in the United States with regards to that than there is in Canada. It might be a signal that I align with this particular group, or that I have these particular beliefs. And in all fairness, I'm not into shaming and blaming. People want to wear a mask, go for it, wear a mask. But where I would be more of a stickler about it is in indoor settings. I think it's important that people put them on when they go inside. I think that will actually have some utility in preventing the transmission of this infection.
Okay, so vaccines, multiple vaccine candidates, on spec production of a number of them, so that if indeed we learn this one is a go or that one is a go, doses will be available. Makes perfect sense. Russia claims to have a vaccine, which has a number of questions around it. At this point, my thought has been the optimistic scenario is somewhere around October 15. There's an announcement made that a vaccine is safe and at least gives 4 or 5 months of immunity. It starts to be rolled out slowly. Healthcare workers, maybe by the end of the year, 2021, high-risk populations. Is that still the optimistic scenario? Where are we on vaccines?
Yeah, I mean, the pace of vaccine development is just staggering. This is phenomenal. There's about 24 that are in human clinical trials. Remember, we didn't know this infection existed 7 months ago. And now, 7 months in, you've got just over 24 in human clinical trials. I think right now there's 6 or 7 that are in what's called phase 3 human clinical studies. That's amazing. I mean, that's where you're enrolling thousands and thousands and thousands of people to answer the question, does it work? And is it safe? So, there's tremendous pace. And of course, we know many of these vaccines are going to fail, but there's so many that are in development and even in advanced stages of development that I'm with you. I do share that optimistic outlook that we'll probably have some successful trials before the end of 2020. I wouldn't be surprised if needles start going in arms before the end of 2020. Hey, I could be totally wrong. I could be way off, and it could be 2021, and these might be a bust. But looking at the data that we have available to us, it's pretty promising. It's not, nothing, of course, is guaranteed, but I share that view. I also like that concept where many governments, or I guess in partnership with the companies, just say, you know what, let's just mass produce these vaccines now. We appreciate that we might be tossing $1 billion out the window if it doesn't work, but the ones that do work, we can already start to roll out vaccine programs. That's a really smart idea. If you've got money to burn, that's a great way to spend it. Because I think at the end of the day, when you balance the economics, loss versus gain, I think this will likely side towards a net gain. I'm not a health economics type of guy, but I'm pretty sure that that's the way the tables will turn, or at least whatever the word, you know what I'm trying to say.
Now, when it starts to become available, it takes a while before we really get towards being able to say, we have ended the pandemic, right? I mean, it's when you took my belief, my understanding is with something as contagious as coronavirus, about 70% immunity is required for herd. 40% of the US is not even interested in getting the vaccine, which is a totally different story. But once the vaccine rolls out, it's still going to be a while, right?
Yeah, exactly. I don't think this pandemic's going to end with a bang, but more with a whimper, right? It's probably going to peter out as more and more people get vaccinated, or as more and more people get this infection and then recover from it and have some degree of immunity for some period of time. So it's probably going to peter out. I think the other thing that it's not talked about a lot is, even though we'll have access to this vaccine in many high-income countries, this pandemic is still going to be raging in many other parts of the world, especially in low-income countries that sadly are, might not have the same access to the vaccine that you and I will have. And I think there's going to be a lot of individuals, a significant proportion of the globe, that will be suffering, disproportionately suffering, because of limited access to the vaccine, because many of the high-income countries are buying it all up and snatching it all up. And I really hope, I know that there are programs, I know the WHO is looking into this, and there are groups looking into this to really have more equitable vaccine programs worldwide. But part of me is a little bit skeptical as to how successful those will be.
We're going to go to a break on the podcast and radio show with Dr. Isaac Bogoch, but our full conversation will be on the YouTube channel. Last time you were on, we talked, at least theoretically, about reinfection. And over the last few days, there has been what I guess is being considered the most specific report of a reinfection, with about 4.5 months in between initial infection and a second infection. So far, it seems the second infection is asymptomatic, which raises a whole other series of questions. Is my understanding more or less accurate? Where is your belief now about reinfection?
Yeah, this is really interesting. So we knew this was going to happen. It was a matter of time. We knew people were going to start to get reinfected. Now, there were a couple of claims of reinfection earlier on, but this case in Hong Kong is actually a very credible claim. They have the genomic sequence of the first infection. They can show the genomic sequence of the second infection. I mean, this is a very credible claim. And we're going to see more of this. For sure, we're going to see more of this. I think what really stands out with this case is that, as you point out, this person was completely asymptomatic the second time. The only reason he was picked up is because he was traveling from Spain back to Hong Kong, and there's screening tests that are performed when you enter the country. They said, whoa, you've got a positive case. Oh, cool. Look, it's totally different from the infection that you had before. This is a different, slightly different strain. It has a different genetic fingerprint of the virus. So, it's hard to extrapolate from one person to what it's going to look like for the globe if people do start to get, when people start to get reinfected. But, what's nice to know, at least in this case, is that this person's immune system was doing exactly what it should be doing. We know this person had symptoms with his first infection, was actually in hospital with the first infection, and the second infection was completely asymptomatic, meaning his immune system recognized the virus, was likely doing exactly what it was supposed to be doing by fighting it off. The guy didn't even know he had an infection, but did indeed test positive. I think there's a lot of unanswered questions. One of them is, to what extent can people who are reinfected transmit the virus to other people? I think that's going to be a very important question to answer. But, I see this, if this is the case, if people can get reinfected but just have a much milder course of illness, that's a huge win. The reason the world has really stopped turning because of this pandemic is because so many people, especially over the age of 60 or those with underlying medical conditions, can get sick and die. Now, if people are vaccinated and it reduces the probability of that, if people, even if they get reinfected after a vaccine, if they get infected after a vaccine, or if they get reinfected and the second infection or the post-vaccine infection is mild, we're okay. We can start to slide rapidly toward what we remember as normal in the pre-COVID-19 era. So if we can really mitigate the morbidity from this infection, and of course the mortality from this infection, I think that's a huge win.
A couple other maybe more speculative things. There's been, I guess we could say, discussion of whether there might be something, not that we would call an immunity, but a resistance to coronavirus, where there might just be, it's not 100% of the population that would easily contract it if exposed. It would be some number smaller than 100%, and that could potentially be factored into our progress towards herd immunity. Is that merely theoretical, or is there any reason to think that there's a portion of a human population of 7 billion that one disease or another, one virus or a bacteria, that there may be some resistance to?
I think that's pretty theoretical. It wouldn't be the first time. I mean, there certainly are other infections where some people are just more susceptible to getting it, and some people are more susceptible to having a more severe outcome with it. And certainly, it could certainly be the case with COVID-19. I think our understanding of that concept related to COVID-19 is still pretty rudimentary. And I think it would be very hard to factor that into models of herd immunity or models of how this pandemic will progress. I don't think we know enough about that to really have definitive statements yet.
Last thing I wanted to ask about, therapeutics, treatments rather than vaccines. There have been so many different studies done at this point, remdesivir, dexamethasone, early, later in the disease progress, convalescent plasma, and monoclonal antibodies. If you had to evaluate everything we know now, under which sort of bucket do you think the most effective treatments will fall? Will they be under the convalescent plasma antibody side, or will they be under the sort of remdesivir, Avigan combinations of drugs side?
I got to tell you, full disclosure, I just don't know. The therapeutics have been, I think, kind of disappointing.
Yeah.
The best data we have, personally, I think the dexamethasone data was the best data that we have. And thankfully, that's cheap as borscht and widely available all over the world. And most people who practice hospital medicine have a lot of experience using that drug because we use it all the time in the hospital for many different reasons. Remdesivir data was sort of okay for hospitalized people that were sick enough to require oxygen. The newer remdesivir data that looked at individuals that weren't sick enough to require oxygen was, I think, rather disappointing. Does that mean that the drug is a complete write-off? No, absolutely not. I think if you have access to it, which is not reflective of most of the world, but if you have access to it and you can use it early on in the course of infection in someone who's sick enough to require oxygen, I'd certainly use it. But some of the more recent data with remdesivir was a little disappointing. The same with the convalescent plasma. I think, while it might have been touted to be something huge, listen, we're going to wait for the randomized clinical trials to come out. We don't actually have that data yet. I'm completely open-minded. I suspect it will be meh. I suspect it will be comme ci, comme ça at best. It might provide some degree of help, but I don't think it's going to provide the degree of help that we would want, or I don't think it's going to be a game changer. Same with the monoclonals. Maybe it'll be a little bit more helpful. I'm keeping my eye on, there's a class of drugs called the interferons. I'm very excited to see what those look like. But in general, I got to say, 7 months in, quite frankly, I thought we'd be further along in the treatment, on the treatment strategies than where we are right now. There's been mostly disappointments. And I think the biggest win was the dexamethasone so far. But I think if you ask 10 infectious disease providers or 10 people that care for sick, hospitalized people with COVID-19, you might get a few different answers on that one.
All right. We've been speaking with Dr. Isaac Bogoch, who's an infectious diseases physician and scientist based out of the University of Toronto and Toronto General Hospital. Always a pleasure having you on, and I really appreciate your time.
My pleasure. Have a great day.